Thank you very much for joining this webinar session that we organized together with Dr. Simão Serrano. My name is Amal Yassin. I am the Product and Business Development Manager at Konica Minolta for the ultrasound. And we have organized this kind of webinar session for you to share with you the experience and the knowledge that the doctors we are working with have. And here today we have Dr. Simão Serrano that I will give the floor to start the presentation and also to introduce himself as well at the start. Hello.
Thank you very much, Amal. Thank you for the introduction. Can you hear me well?
Yes, we can hear
Okay,
you well.
thank you so very much. So it's my great pleasure to be here with you. Good morning or good afternoon, depending on the area of the globe you're watching this webinar. It's a great pleasure for me to accept this kind of invitation from Konica Minolta EMEA to present this theme about high frequency ultrasound and advanced power Doppler. And as you can see, the subtitle says that this is a new paradigm for interventional pain management, but because in the reality, we are speaking about technology that was only available some 10 to 15 years ago. It was only available in stationary ultrasound machines, high-end ultrasound machines, very expensive machines. And now you bring a new vision on the use of a portable but very powerful machine, in this case from Konica Minolta. And also, you may think, how can this or a small portable machine also have advanced power Doppler? And that's the case. Yeah, and this can be, as you will see, very important for evaluating patients with pain. My name is Simão Serrano. I'm a rehab doctor and also a certified interventional pain sonologist by the World Institute of Pain. And I work in the rehab center, a rehabilitation center in the center of Portugal, Hospital Rovisco Pais, and also I work in the pain department at the Mediotejo Hospital Center, also in the center of Portugal. So it's a pleasure for me to start this presentation to speak with you about firstly about high frequency ultrasound. We will see that high frequency, when you speak about high frequency, we're speaking about probes that can have higher megahertz. We're speaking about 18, 19, 20, 21, 22 till maybe 24 megahertz. We now have probes. The paradigm or the change of paradigm is that you can use those high frequency probes with a very portable and affordable machine. And we'll speak about several clinical cases. But firstly, since we're speaking about nerve ultrasound, we're speaking about an area that I love, that is nerve ultrasound. We'll speak a little bit more about how do nerves look under ultrasound. And also we'll speak about tracking nerves, and you see many advantages over other imaging modalities such as MRI. And also then we'll think about how can I use not only for nerves, but how can I use high frequency for evaluating superficial and also deep structures in the human body. Because sometimes we think high frequency, it will not be possible to look for deep structures with this kind of probes, but this is not the reality. So starting now with high frequency ultrasound. So the past was this. So this video was taken maybe 10 years ago using a stationary machine. And here we're trying to evaluate the median nerve. These are the flexor tendons, and it's so difficult to analyze the nerve to see the epineuron. We can see it, but very difficult to identify the perineuron or the fascicles of the nerve. But the reality is that technology evolves as everything, and now we have so much more good quality. And this is all the pictures you'll see are taken from these portable machines. You can see a dynamic movement of the flexor tendons, and you can see perfectly the median nerve. You can even count the fascicles of the nerve. You can see the ulnar nerve. You can see the Guillain Canal. You can see the ulnar artery. All of these with high definition. This is the present. So why high frequency ultrasound? So when you use, in this case, I'm speaking about the linear probe that goes from 4 to 18 megahertz. The thing is, these probe is both compatible with the high-end machine, the SonoImage HS2, but also compatible with this smaller machine, new machine, the MX1. That is the one that I use in my practice, my private practice. And here you can see that it is a small machine, touch screen. You can even attach a camera if you want to discuss your findings with other colleagues for multidisciplinary discussions, which I also use. And still on this machine, on this platinum machine, you can even put a high frequency probe. Um, this probe is perfect to evaluating joints too. For instance, for rheumatologists, amazing for analyzing fingers, toes, and superficial structures, for instance, at the ankle level. And also have an excellent resolution, as you will see, and also outstanding Doppler sensitivity is something that even with stationary machines, sometimes I cannot get this kind of sensitivity, and we'll explore more this afterwards. And if you are a beginner on doing ultrasound, you can even use this new technology that is the simple needle visualization in order to see the needle in all the trajectory, um, kind of trying to show to us the needle in the deeper levels, such as an echogenic needle will do, but here also only using an advanced algorithm. So why I use high frequency ultrasound. For instance, small rotator cuff tears can be easily missed in some of the MRI exams. And with these high frequency probes, we can analyze even small ruptures, as we'll see. And sometimes it will avoid the need of MRI exams. It also is very important for surgery planning. I have many colleagues, mainly upper limb surgeons, that ask me to study nerves before doing nerve releases or nerve surgery to understand where is the lesion, and more importantly, to understand if there is any architectural change to the nerve, so the orthopedic surgeon can perform a proper surgery. And for instance, if you do sonosurgery, for instance, if you want to do sonosurgery for the carpal tunnel, for instance, it's very important to have a high frequency ultrasound, for instance, to know where is the thinner motor branch of the median nerve, and also to see the Barrettini anastomosis after the transverse carpal ligament, that is so important to avoid a lesion of digital nerve. So what about nerve imaging? What can you say? That is low cost, is non-invasive, it's very easy, and it's very fast that we can track the full length of a nerve, for instance, a median nerve, as we'll see. Also, it has many advantages over MRI using ultrasound, nerve ultrasound. Higher spatial resolution, the ability of explore long segments. For instance, we can track the median nerve from the axillary region till the tips of the fingers. And it also allows static but also dynamic evaluation, which is a change of paradigm comparing to the MRI. And here you can see again the same image of the median nerve comparing to the MRI, and compare the resolution. Here you can count even fascicles. Here it will be very difficult to understand what's happening inside the nerve. Obviously, it's important to know that the transverse section of the nerve have this honeycomb-like appearance because mainly of these hyperechoic septa that are no more than the epineuron and the perineuron that is surrounding the fascicles. And this is very important to understand this kind of structure. On the long axis, the nerves are different. They have this kind of bundle of straws appearance. This is the median nerve on the forearm level on the long axis. And you can see this fascicular architecture. But the question is, do nerves always look the same? The question is that that's not always the case. Because if you go, and here is the cervical spine, you see the C5 root coming off in long axis, you can see that the image looks hypoechogenic. And this is because of the plexiform arrangement of the nerve, as you can see on the picture. And it creates this kind of image that is not the typical bundle of straws. As you go distally and peripherally, you'll see that the nerve acquires this cable-like appearance. And this is because of the high degree of somatic or organization of the nerve. So for instance, if you see a lesion of the median nerve on the most ulnar side of the median nerve, For instance, at the forearm, the clinical will be more on the most ulnar part of the part that is innervated from the median nerve. So there is a correlation because of this somatic organization. What about injections of nerves? Because we'll see a lot of images and clinical cases of injections and nerve either dissection. So why do we do it? Why do we block nerves? Specifically because we want to use fluid to separate nerves for the surrounding tissues. It can be fascias, ligaments, fibrosis, and in order to treat the neuropathic pain. And what's the rationale? Every nerve around the nerve have the nerve innervorum and the vasa nervorum. The nerve innervorum regulates the function and the discharge of sensory motor or mixed nerves. And we have the vasa nervorum that is so important to supply nutrients to the peripheral nerve and the veins that drain away the metabolites from these nerves. So if the nerve is some kind of way pinched, these kind of structures, fundamental structures, do not work properly. So that's why this extrinsic compression will leave potential stasis and accumulations of toxins and impair lymphatic drainage. And it's not by chance that when an orthopedic surgeon it cuts the transverse carpal ligament, you can see immediately the nerve acquiring a different color, a more pink color of the nerve, because obviously the nerve was pinched, and after the cutting and releasing the transverse ligament, the nerve acquires a better color because the vasa nervorum starts to work properly. So we're trying to replicate this with fluid by dissecting the nerve. So there are many RCTs that show that this is a safe and effective technique. For instance, for the CTS, the carpal tunnel syndrome treatment, which is the most studied, I recommend that if you're starting, you do it on an in plane. You see the nerve on short axis, and you do a hydrodissection around the nerve. Initially, with the bevel, the needle bevel positioning up to release the inferior part of the nerve, and then changing to the upper part of the nerve to create a good donut with your local anesthetic or dextrose 5%, whatever you're using to either dissect the nerve. The autoplay technique is also possible to do, but it's reserved for more skilled and trained hands when performing this procedure. This is hydrodissection. Sometimes we can't do it with the compartment blocks. And here is an example of doing a compartment block blocking the pudendal nerve. Here you see the iliac spine and the sacrospinous ligament, and you're doing the compartment block of the pudendal nerve. So now tracking nerves. Let's start with an example for pain management. For instance, my friend John Tran and his team, they helped us to understand the innervation of the shoulder. So now we know perfectly well the innervation of the shoulder. We know that the suprascapular nerve here on the suprascapular notch give important branches for the upper part of the joint. And here on the posterior part, we will see another, some more branches from the suprascapular nerve, branches from the axillary nerve that will innervate the glenohumeral joint. So we know now the relevance of all these nerves. Here I show an example how to track the suprascapular nerve proximally going from the brachial plexus. So now we're tracking here the brachial plexus, we're going down, and we see the different roots coming out from the foramina. And then we will see the C5, C6, C7, and we know from the upper trunk, the suprascapular nerve will detach itself. You can see here the suprascapular nerve that is going a little bit posterior from the brachial plexus, and then it will reside beneath the omohyoid muscle. Sometimes you can even ask the patient to swallow a saliva to see the muscle sliding, and you can the suprascapular nerve. And you can even block the nerve here if you're confident enough, because here you'll know that you'll some kind of do a complete block of the suprascapular nerve, which is not always the case when you do on the posterior approach. This is the posterior approach that we normally use. We see the superior angle of the scapula. We slide our probe, seeing the scapula, the superior border of the scapula. We continue with our probe laterally until you see not the ligament as many books says, but here we'll see the fascia of the supraspinatus muscle, the inferior fascia, and the nerve lying beneath. And here, if you want, you can use power Doppler to see the suprascapular artery, which is not mandatory. The nerve is there, is lying beneath the fascia, and you can perform the block from medial to lateral. So the axillary nerve approach, you'll see the teres minor here. Here is the teres minor. You have to put, you're cutting your infraspinatus and you're cutting your teres minor and short axis. This is the image you'll get, deltoid, teres minor, and on the tip of the teres minor, you'll see the axillary nerve here residing just there. Then you can move your probe more lateral and anterior, and continue to track this posterior circumflex humeral artery, which is a perfect key landmark to find the axillary nerve that will be here, as you can see on the picture, very close to the periosteum at this level here. And this will be the approach for the axillary nerve and a way to find it. Obviously, keep in mind that if you do a block of the suprascapular nerve itself, the patient will lose function of the shoulder. So I only do cryoablation or this kind of ablation techniques on the suprascapular after the brachial plex on the or in the posterior side, only if there is no rotator cuff, no supraspinatus, no infraspinatus, there is a full rupture, I will do the main trunk. If not, we need to use another strategy. We will need to use a pericapsular ablation of the shoulder joint, such as we do it for other joints like hip with a pain block. We'll try to address all the little sensory fibers that are coming from the main trunk of the suprascapular, for instance, and the axillary. We are doing ablation of the sensory branches to the joint and not the main trunks, not the main trunk. So the person that has a rotator cuff will not lose function. Here's an example of doing so with cryo, and my ice balls will freeze around the glenoid bone. Another important topic is that it's not enough to do the posterior part of the joint. Don't forget here the acromial branch of the lateral pectoral nerve, that is this small branch that runs above the coracoid process. I'll show you an example of this. This is the lateral pectoral branch that's going just above the coracoid process. And as many anatomical studies with cadavers show, they'll give branches for the subacromial area, the acromioclavicular ligaments, and also in some cases for the joint itself. So don't forget to check for on the short axis, have an image as we can see the clavicle, and on the same level the coracoid process. And here in between, we have the vascular bundle, and the nerve will be just close here, as you can see at this level. This is the lateral pectoral, the acromial branch of the lateral pectoral nerve, and should be addressed to decrease the pain. For knee, we also know very well the genicular nerves. We know their distribution, but when I started, people say it's impossible to see the genicular nerves. You only see if at most you can see the arteries, the genicular arteries. But this kind of thing is not true anymore with high frequency. I show you an example of a superior middle genicular artery, which helps a lot with the Doppler, the power Doppler capabilities and technology. But you can see clearly the genicular nerve there, just next to the artery. And this is possible to see. For a nerve block, a genicular nerve block, you can do a direct approach like this. In order to do a radio frequency, you'll want to put your needles parallel. Two needles, I do bipolar, parallel to the nerve. How do you do that? With the power Doppler, you change your probe 90 degrees, and then you can see the artery on the long axis clearly and beautifully portrayed here. And you'll put a needle or your radio frequency needle a little bit distally and another one a little bit proximal to the artery to see the and to perform the ablation. Don't forget to put your brightness of your screens or mobile phones on the max so you can really see the videos and images. It can help you to see better those images. The same for the inframedial genicular nerve. Always track the medial collateral ligament below the knee, and then you'll be able to see the genicular, the inferior genicular artery, and the genicular nerve next to the artery. So it's beautiful that now we can see these structures. Don't forget also the infrapatellar branch of the saphenous nerve. Specifically in my clinical experience, after post-total knee arthroplasty, many of patients complain with neuropathic pain, sometimes on the inferior part of the scar. So sometimes it can be related to neuromas of these nerve. I will show quickly a video. As we can see, the nerve is here, and I'm going down, I'm going distally. You can see how close the nerve is passing through the meniscus here, the medial meniscus, and then the nerve, as we curve to the patellar tendon, divides into the distal branches, and here you can see the patellar tendon. Yeah, it's very important to train our eye to follow this. Don't forget, this is, as the name indicates, the infrapatellar branch of the saphenous nerve. But in some cases, there are some anatomical variations, and this nerve will come from the medial cutaneous nerve here of the thigh, not from the saphenous nerve. After this, so if you find a neuroma, you can do a block. Here I'm doing a block of the infrapatellar branch of the saphenous nerve. And then I do cryo if that helps with neuropathic pain after after total knee arthroplasty. I'll do cryo on that nerve. Sometimes I also need to do cryo of the anterior femoral nerves here on the thigh, on the anterior thigh, that also are damaged with the scar tissue. And sometimes if the patient complain with neuropathic pain on the skin, it can look for the neuromas on those nerves. So now starting with peripheral neuropathies, which is also very interesting to use high frequency ultrasound. Let's start to do a tracking of the median nerve. How can we show that we can see and track easily the median nerve from the axillary region until the distal part? So I'll show you here that we are here on the axillary region at the moment. We can see the axillary area where the plexus lies in. And we can see also now the division on different nerves, median nerve, ulnar and radial, and musculoskeletal nerve. And now we'll focus here on the median nerve. We can see the arteries, the axillary artery and vein, and then I will track it down and see how we can perfectly assess the nerve, always in closer relationship with the brachial artery, and can even count the fascicles of the median nerve. We can check for impingement in several parts of the length of the median nerve in the arm. There are many places where it can be pinched. The Struder's ligament. We can continue to go down. Now you see the elbow region. You see that the median nerve now will have to pass through the pronator teres muscle after this. It will now go between the two heads of the pronator teres along with the ulnar artery. Also a possible point of compression of the median nerve, specifically in manual workers that have to use a lot of pronation, resisted pronation. And now, as you can see, it will have to go deep and cross this wall, this black wall. This is the sublimis bridge of the flexor digitorum muscles. That is also a point of impingement or entrapment of the median nerve. And then as you continue for the forearm, you'll see that the median nerve has continued to have this fascicular pattern. You can see that is below we have the flexor digitorum profundus, and here the flexor digitorum superficialis. And we can beautifully continue to track it down. Now we can see the pronator quadratus muscle here. And it can go down, down, down until it enters the canal, the carpal tunnel. And here you can see perfectly even the palmar cutaneous nerve that normally is lying on the sheath of the flexor carpi radialis tendon. You can see the palmar cutaneous branch of the median nerve, which is obviously spared when we have a carpal tunnel syndrome. And now we see the carpal tunnel itself and the nerve. We can see even the key landmarks for the carpal tunnel. You can see the scaphoid, you can see the pisiform for analyzing the proximal part of the carpal tunnel. And it can even continue. You can see how thin the transverse carpal ligament is. And I can continue to go a little bit distally. This is the Guion canal with the ulnar artery and ulnar nerve. And I can even go distally, see the flexor tendons here, the flexor pollicis longus here. And it can continue still seeing the transverse carpal ligament. I can continue to go down, down, and even see now the division of the median nerve on the three common digital nerves. So here is the last part of the canal, trapezium and the hook of the amate. And now you see the division of the median nerve on the distal branches, the common palmar digital branches that it will eventually give origin to the interdigital nerves. So it's beautiful. I can see everything. You can see even small neuromas if you need of small nerves, interdigital nerves with these kind of machines, which are not possible with low frequency ultrasound probes. So how does it look a normal median nerve? This is a more or less normal median nerve. You can see the fascicles, and this is a very abnormal, and you can see here how the fascicles are completely compressed. You cannot see fascicles, they are completely compressed. As you can see, the measuring of the cross-sectional area is 20 square millimeters, which is much higher than the 11 or 12 square millimeters that are accepted as normal. So this will be like a person that obviously I would send for surgery because of the high cross-sectional area. It's not a subtle suffering of the nerve. This is a very severe case. So how can we see this loss of fascicular pattern? Here you see a normal nerve, and as I go distally to the carpal tunnels, look as the fascicles get less visible, and you have this hourglass signal as here the transverse carpal ligament is compressing the nerve. This is distal, this is proximal, this is the carpal tunnel, and this is the nerve on long axis, and we have this beautiful enlargement of the fascicles just proximally to the impingement that is induced by the transverse carpal ligament. Now I want to show you an ulnar nerve. This is an ulnar nerve, a normal appearance here on the ulnar groove. And here the nerve going in between the two heads of the FCU muscle. So just a normal appearance of the ulnar nerve on the elbow. And now let's see an abnormal. So here we have the ulnar nerve just above the elbow, and as we enter the bicipital, the ulnar groove, sorry, you can see a great enlargement of the fascicle, the loss of fascicular arrangement. And then if you continue going down, look again how the nerve is getting enlarged between the two heads of the FCU, the flexor carpi ulnaris, and you can see how different the nerve is from a normal patient. Also, just wanted to share this case. So the orthopedic surgeons, they refer me the patient after releasing the ulnar nerve of the ulnar groove. After the surgery, the patient continued or at least started to complain with a new neuropathic pain in the elbow region, which was not the case before. It was only at the end level. And so they asked me to understand what was happening. And so we can see here the ulnar nerve, and you see a small nerve there next to the ulnar nerve. Eventually you'll see it a little bit better. You can see the neuroma here. The ulnar nerve is down there, and there is another nerve. This is a neuroma of the posterior branch of the medial and brachial cutaneous nerve, which is nice because we may think that in the ulnar groove only the ulnar nerve lies, but we can have this posterior branch of the medial and brachial cutaneous nerve that was obviously damaged during the surgery. And then eventually what we had to do is like a standoff technique to block the nerve, and not the ulnar nerve that is lying beneath, but the neuroma. So, and the patient was having a relief after this. So keep in mind that there are also anatomical variations. Another case of a neuropathy of the superficial radial nerve. Sometimes this happens after Duchervin's release surgery. Patients can have a lesion of these distal branches. This was the case, and after the first surgery, the patient was submitted to another surgery, a surgical release of those distal branches of the superficial radial nerve. And eventually, because of no improvement, she underwent another surgery to put neurotubes around those distal branches. Very complex surgery. But still no improvement on neuropathic pain. And you can see here the area of the allodynia at the wrist level. So because of this, we tried several things. We tried cryo without success. So we tried to do another thing. We tried to use botulinum toxin to release the distal nerves. Here you can see distal nerves of this is the first compartment, and here you can see distal small nerves from the superficial radial nerve, and then we do a hydrodissection using botulinum toxin without local anesthetic. So it required to do proximal blocks to relieve the pain from the skin before pinching the skin, but then we could do a hydrodissection of those small nerves with Botox. Why Botox? Because Botox normally is used for spasticity, but more and more Botox botulinum toxin is being studied for its neuromodulation effect on nerves and the peripheral nerve system. So interestingly enough, after the procedure, two procedures, the medium and the max pain decrease, and the neuropathic descriptors also lowered a lot using the DN4 scale. So an interesting case of a potential use. Here you can see the neurotubes. You see here, this is a neurotube and the nerve inside, but I was also releasing the neurotubes from the skin to improve the efficacy of the procedure. Another interesting example of a 21 years old man that had this suicidal attempt using overdose with IV drugs, and he had this what is called a drug-induced compartment syndrome of the right leg. So he had like no dorsiflexion, no plantar flexion, and had like hypoesthesia on the territory of the common fibular nerve and tibial nerve. So what you try to understand is any difference on the nerves because of this, because of the compartment syndrome that is so frequent even in the orthopedics setting. Uh, So here is the mythosis where you can see where the sciatic divides for tibial and common fibular nerve. You can see how enlarged the fascicles are. It's notorious, and here I'm following the common fibular nerve when it's going to the fibular head, and it's notorious how enlarged all the fascicles are. How is it different to a normal side? So this is the abnormal that we just seen, the mythosis, and here on the normal side with the tibial and the fibular nerve, and look how different the fascicles are. So this also enlightens you when you add neuromuscular ultrasound to your clinical examination. Now let's speak about neuralgia paresthetica. We know that this can happen due to different factors like tight belts, or even when orthopedic surgeons can need to take some of bone graft from the area. And here you can see an abnormal and normal appearance of a compression of the nerve. Here you can see abnormal. You see how enlarged it is next to anterior superior iliac spine and the ilioinguinal ligament. You can see the nerve here, and you can see how enlarged it is next to the spine. You can see here how enlarged the fascicles are, and this is the normal appearance on the right side. No, not the normal appearance. This is just the abnormal one on the long axis, and you can see how large it is. This is the same nerve, but on long axis, curving around the anterior superior iliac spine. Um, this is a great example that confirms your suspicion. And here that's here another example of normal. This is the normal one, the normal lateral femorocutaneous nerve that will eventually divide to the anterior and posterior branches. These are the googles. This is fat tissue tunnel. And on the abnormal on the right, you can see how enlarged it will be. Look how enlarged the nerve is comparing to the normal site. Don't forget to also track the nerve a little bit more proximally to the ilioinguinal ligament, where sometimes the compressing of the nerve starts. But here very easily to see the the fascicles enlargement here. You see here on the right. And here is the skin distribution of a lesion. Here you can see that the patient underwent here uh, um, um, a surgery to take some of bone graft for another surgery at the ankle level, And here you can see in the enlarged fascicles, and I'm doing the hydrodissection, which is commonly very effective for this situation. The hydrodissection, you can see I am dissecting the inferior part of the nerve, and then eventually I will move to the superior part of the nerve. Always try to accomplish the donut effect, like dissecting the inferior and the superior part of the nerve. Another great example, traumatic leg injury on the anterior lateral part of the leg. And here to ultrasound on the long axis, you could even evaluate the deep fibular nerve that is completely injured. There is nothing less. There is a gap between both. And this can be very important information to give to the orthopedic surgeon. He may ask, is the nerve intact? Is a partial or is a total cut of the nerve? You can provide this information via ultrasound. Another great example, an athlete that had a very severe traumatic injury of the knee with complete luxation, posterior luxation of the knee, and then he had this complaint. He has a flat foot, no strength whatsoever, specifically for the dorsiflexion. The plantar flexion was more or less okay, but the dorsiflexion was a grade 0. What can we say? Obviously, for sure, there was a stretch of the nerve, but where is the nerve lesion? Is it most commonly here at the fibular head level, or is it more proximally? What kind of information can we give to the orthopedic surgeon? For instance, here you'll see after the methosis, this is the sciatic nerve. The tibial portion is okay, but the fibular nerve is completely disarranged. You can see the fascicles are not longer visible individually, and this is the thickness. This is the long axis of the common fibular nerve. You can see how thick it is with a loss of that fascicular arrangement. So based on this, I could provide to the orthopedic surgeon two informations: the location, that the lesion was proximal next to the bifurcation of the sciatic, and I could say to him the length of the lesion of the common fibular nerve. Because of this, he would able to do a nerve graft, taking from another location with a specific length needed for this patient and for repairing the nerve. So very interesting case. Obviously, the recovery is a long process on these cases after surgery. Another two examples, very interesting cases of a sudden non-traumatic foot drop. One case is of a 40 years old man with a progressive drooped foot. And here you could evaluate, this is the fibular nerve, that next to the fibular nerve, this is the tibial and this is the fibular, there was an intraneural cyst that was impossible to expirate. And due to this reason, he underwent surgery to remove the cyst around the nerve. As you can see, beautiful portrait here. This is the fibular nerve, and you can see the cyst that was removed surgically. In another case, a 49 years old with a sudden drooped foot, it was not needed to perform the surgery because you can see the fibular nerve here, and there was here this extra neural cyst coming from the superior tibial fibular joint that was compressing the nerve, and then we were able to expirate and fenestrate the cyst in order to relieve the pressure, and eventually this patient didn't get the surgery. No surgery was needed, and he could recover his deficits. Always look for patients that were getting surgery and from the ankle fracture, for instance. If they are very well when it comes to mobility, but they complain with neuropathic pain on the dorsal, on the foot, look for the superficial fibular nerve, because there are many iatrogenic lesions of this nerve. Here you can see the superficial fibular nerve that comes superficial around 12 centimeters from the lateral malleolus, and you can see a nerve lesion next to the plaque and screws. Here you can see a lesion there of the nerve just next to the plaque and the screws, as you can see there. And then eventually you are able to do an injection of the neuroma. So this is a long axis of the superficial fibular nerve, and we call it a neuroma in continuity because there is no cut of the nerve, but there is definitely a bump there on the nerve due to the iatrogenic lesion of the nerve. And you can see here the long axis and the beautiful bump of the nerve. So musculoskeletal application for superficial structures. You can see everything. You can see the flexor tendons at the finger level. You can see the distal insertion on the distal phalange, and you can see the nerve beautifully through the finger. You can, as I told you, you can even see the small interdigital nerves until the more distal part of the fingers. And you can even see at the wrist level many things, like for instance, the lesion of the scaphoid lunate ligament. Here, the scaphoid and lunate, and as we do ulnar deviation, as in the X-ray, you can see a complete opening of an increased gap between the two bones. We can increase the instability of the wrist, and if not treated, can lead to an early osteoarthritis of the wrist with select lesion. So how dynamic evaluation with using high frequency ultrasound can be beneficial to early detection of this kind of tears, and very important tears at the wrist level. Meniscus, we can also evaluate between meniscus. People say that it's impossible to look for meniscus with ultrasound, but you can even evaluate horizontal tears of medial meniscus. You can clearly evaluate the lateral meniscus here, big lesion here on the most anterior part of the anterior horn of the lateral meniscus. You can see how extruded the meniscus is, even making the lateral iliotibial band to be overstretched. And rotator cuffs tears. I told you that you can see small tears. Here is an incomplete full thickness rupture or tear of the supraspinatus on the long axis, on the short axis. Beautiful scene here. You can see the short axis here, and you can see very small gaps between the tendons that are involving the full, in this case, the full thickness of the tendon. These are very small. And in those cases, when they're so partial, we can try to do injection with leukocyte-rich PRP to induce repair process. Here I'm putting my needle inside the tear, into the tear, and putting a little bit into the tear, and then at the bursa level, because the bursa will also um, store a lot of PRP that can be later used to induce repair at the tear level. Here I'm putting the PRP on the bursa level. This is the long head of biceps, and we do it here. Complete rupture, beautiful scene. You can even see the tip of the tendon that is left, and you can see the complete rupture here on the short axis, complete rupture and full thickness. We can do calcific tendinopathy barbotouch technique. This is a calcific deposit. I'm getting in with the 18G needle, and then I'm doing the lavage to clean the interior part of the calcification, so the calcium will get back to my syringe, and the patient will have a lot of relief of pain because of this. So deep structures. Can you see, for instance, the distal insertion of the biceps brachii tendon? It's also a struggle to see this tendon. Looks superficial, but sometimes difficult. You can see perfectly here the insertion at the bicipital tuberosity of the radius of the distal biceps brachii tendon. But also, if you can't look on the long axis, you can look on the short axis where the tendon is clearly see here next to the ulnar artery, and it goes distally to insert at the radius. You can see beautiful here, the tendon on short axis, and it's going down, down, down until the insertion. I show you an alternative way of locating the biceps tendon. You have to put your probe here on the middle side of forearm, and you put your probe on the long axis of the tendon. You'll be able to see this beautiful, beautiful distal tendon. Here an example of a normal tendon and abnormal with multi internal tears of the tendon, and I'm injecting here PRP, leukocyte rich, to try to increase the repair process of the tendon. Again, can you see hip? Can you see hip tendons with the high frequency probe? Yes, you can. For instance, here I'm showing you a calcific deposit at the medial gluteus. so at the hip. So it's possible to use high frequency even for deeper structures, using, for instance, the trapezoidal effect with your probe. Can you evaluate shoulders? Yes, you can see here the glenohumeral joint on the posterior side, and you can see the accumulation of fluid in the joint. It is clearly abnormal. You see the accumulation with external rotation. It can even do hydrodilatation from frozen shoulder. As you can see, I'm injecting a high quantity of fluid inside the joint to do the hydrodilatation for frozen shoulder. Now we can even use the anterior approach for shoulder. And instead of using the posterior approach, you just look for the long head of biceps in the rotator cuff interval, and you put your needle between the long head of biceps and the coracohumeral ligament, and you'll be able to access the joint. You can do it for like intraarticular injection, but also for frozen shoulder at this level. Now to end, advanced powered Doppler. Why is it important? It can be used for chronic tendinopathy, for evaluation of ruptures and tears of ligaments and tendons. And I'll bring examples where you can use it to know when not to inject. So power Doppler, at these machines, they have an excellent resolution, and I told you, an excellent Doppler sensitivity for micro blood flow I tell you, with no significant frame rate degradation, which is not always the case, even with high-end machines. And I'll tell you about here this different technology. This is the simple clear flow. It's a novel technology that is based on power Doppler, but as you can see, the sensitivity to even very thin blood flow, it's got by the simple clear flow comparing to the power Doppler. So this for us that need to evaluate tendons and ligaments, this is outstanding, realistically outstanding. Another thing that when you use simple clear flow, you can move your probe and you'll have less artifacts comparing to normal color Doppler. So you can even do tracking of ligaments, and still the probe will capture and the machine will capture this low velocity blood flow, which is quite incredible. For instance, in the Kervin syndrome, can you use power Doppler? Yes. For instance, in the Kervin, you can have a problem that is an isolated problem here at the extensor pollicis brevis. It's not the full compartment, just this portion of the extensor compartment. And then you can use the power Doppler to see the power Doppler signal on the sheath of that specific tendon, which is quite amazing to see the information that it gives you. Here at lateral epicondylitis, you can see a small tear and the Doppler signal in across the tendon. And in those cases, you may consider the fenestration and the deposition of orthobiologic such as PRP, or I use myself more and more botulinum toxin at the tendon level because of this neuromodulation effect with very nice results. Another example, I normally perform greater occipital nerve injections, but as I was looking for the oblique capitis inferior muscle, I saw this big vascular structure, which is normally not very common to see. And because of that, I stopped. I didn't do the procedure. I went for MRI, and you can see a very enlarged deep cervical vein with a tortuosity. So that obviously the ultrasound gave me some advice to look for another exam. Here, a case of chronic patellar tendinopathy. This was a young patient that underwent a medial patellofemoral ligament reconstruction on the patellar part, but after the surgery, she started to complain with patellar tendinopathy. And you can see here, beautiful with the simple clear flow, how there is a tendinosis and a tendinopathy on the most medial side of the patellar tendon. And here is on the short axis. You can see beautiful images that the 2D alone doesn't give you. Here, quadriceps chronic tendinopathy. Here you can see how simple clear flow. I can move my probe and still have a good captation of the signal. And this, you could say there is nothing happening there, but then you put the simple clear flow and you can clearly see an inflammatory process going on with neovascularity. Here's the same one, but on the short axis. You can always evaluate on the long, but also on the short axis to see which part of the tendon is mostly affected. Another example of a pole dancer instructor, 39 years old. She started to complain with progressive anterolateral leg pain, and this is the tibia. This is the anterolateral muscles, the tibialis anteriors and tibialis anterior muscle, and then you can see that from within the muscle, you see this enormous hypoechoic image that was very suspicious for me initially. As you can see on the long axis of the cyst, it was a very anechoic image with fluid, but I was not understanding what was this lesion. So she underwent MRI, which showed it to be an intramuscular cyst, but still she was referred to an orthopedic surgeon to a further biopsy. Here, another great example of 45 years old man with a colon cancer, only with known hepatic metastasis, that underwent surgery for the colon cancer, but then eventually came to me with pain on the sacroiliac joint. I put my probe in to see anything because of the medical history, and immediately I noticed this suspicious mass next to the sacroiliac and the iliac bone with this increased signal of power Doppler, very intense signal. Power Doppler signal. And because of this, I immediately asked for a CT scan, which shown, as you can see here, a secondary lesion, a metastasis that was promptly treated using radiotherapy. So no injection. So I didn't inject that sacroiliac joint. This is just a call for attention that if you're using ultrasound, the moment that we put the ultrasound on a patient, we are responsible for what we are seeing. So if I would not detect this or ask for the CT scan, this will take longer. There will be a delayed diagnosis. So this is why it's so important to integrate the clinical history of the patient. So take-home messages. High-frequency ultrasound is a great addition for diagnostic and interventional procedures. It increases safety, allowing for new therapeutic alternatives. I spoke to you about cryoablation, for instance. It has a broad application for pain management, spasticity, and treatment and diagnosis of cerebral musculoskeletal conditions. It has a high resolution, but still with excellent power Doppler usability, and they can even be used for scanning of deeper structures. And don't forget the advanced power Doppler. Even if you're tracking nerves, we know that the landmark for many nerves, for small nerves, are the arteries that accompany the nerves. So use advanced power Doppler to detect even the very small blood flow that those arteries sometimes have. For instance, the genicular arteries is one of the examples we talk about. And if you want to know more about tracking nerves, I can then provide you QR code in order to see other videos from tracking nerves of the upper limb. I think that's it.
Thank you very much
I hope you, yeah. Thank you very much. And I don't know if you have any questions.
Yes, so now we are able to take a few questions if we have a few times left in the meeting. So if anyone has some questions that they want to ask, please feel free even either to raise your hand or put the questions in the chat box. But if there aren't any, thank you very
Please be
much
free if you
for,
want to ask. Yeah. We are eager to answer any questions that you may have. Yeah.
So,
Okay. Yeah.
well, I see that there is no question. If questions may come maybe after, you can send us an email. I will put the email in the chat box, and I will be maybe sharing it with Dr. Serrano to answer it. Yes, I think someone has a question. I will unmute you one moment if you want, or you can type it in the...
You can type in on the chat, or you can just ask
Yes,
directly.
thanks again. Yes, you mentioned you are already used more and more Botox. Also more than PRP, on which I didn't release much data about Botox and treating pains. So, and do you use it perineural or also for other reasons for pain management?
Thank you very much for the question, Ihab. Yes, more recently, there are some evidence, even on rats too, that using botulinum toxin around nerves can have a profound effect on the neuromodulation of pain, specifically on the dorsal root ganglion. It's shown that can decrease the peripheral sensitization that we often observe in those patients. So I try to do on refractory cases. I'm trying to do more perineural hydrodissection with botulinum toxin. And also, as you were asking, this is off-label, of course. This is not on-label. This is off-label use. But I try to do the hydrodissection of small nerves, as I shown that in that clinical scenario I told you about the curve release surgery. And I tend to use more and more in some situations. I told you in lateral epicondylitis, I have very good results with just one session of fenestration of the common extensor tendon at the epicondyle level using Botox. I'm not using it in the muscles as it's normally described to decrease the function of the muscle and then decrease the pain on the entheses. No, it's just doing fenestration on the tendon itself and using the Botox in the tendon, not the muscle, in order to do the neuromodulation of pain, the peripheral neuromodulation. That's it.
And do you need to repeat it all 3 months, right? Or
The
it's
PRP, yes. PRP, normally I need to
Botox.
repeat every, but with Botox, I'm just doing one with very nice results.
Okay, thank you.
That's why I'm moving because of the price. Like one botulinum toxin can cost around, here in Portugal, 130 euros, but PRP will be much more expensive. And my results are good with Botox, so I'm doing Botox. But again, it's off-label.
Okay, thank you very much. Yeah.
There is another question. Is SCF better than powered Doppler in terms of sensitivity to detect microvascularity?
Much better, much better. Much better. This kind of simple clear flow, you only have, I can tell in the hospital, I use a very high stationary machine, and you can only have it with a high-end machine. And now you're using this in a portable machine in your private practice. I show you the graph on the slide that the simple clear flow can start detecting much earlier comparing to the power Doppler. And this is very important. It's also true that we know how to change the parameters, the phlebology, the parameters of the power Doppler. If you don't adjust the sensitivity of the power Doppler and all these different characteristics, you'll not have any signal. So it's important to know how to capture that signal. But that definitely, as I show in the graph, simple clear flow will allow an early detection of the micro vascularity, and also with less artifacts, which when you have Doppler and you move your probe, all the image is a mess.
Okay, great. Thank you for your answer. And I don't see any other questions. If there is any one last round, raise your hand. Otherwise, I think we will conclude this session. Yeah, for now, I don't see any hands raised, so I think we are all good. Thank you again, everyone, for joining in and participating at this session. Hopefully, it was a very insightful session for you, and you managed to get some of the knowledge of Dr. Simão, that he has been using the ultrasound for pain management quite a while. I see another question. One more second. In case of tendinosis, do you use Botox or with or without? 1 second. Local anesthetic.
It's not it's not very well studied, the effect of local anesthetic on the botulinum toxin molecule. So as I told you in that clinical case of the Ducrevin syndrome, I used Botox alone for hydrosection, and I did proximal block of the lateral antebrachial cutaneous nerve and the posterior antebrachial cutaneous nerve. So that was the way to avoid need to use local anesthetic just beneath the skin, so I could use only Botox. So if that's the case, I use the same approach as PRP. So you shouldn't put local anesthetic in the tendon and then put the PRP, because you know that local anesthetic will decrease the effect or hinder the effect of PRP. So always try to do proximal blocks to anesthetize to be able to pinch the skin without pain for the patient, but without using local anesthetic at the spot that you are treating.
Okay, I hope that answered the question. Great.
So you have my email if you have any other questions. It's simao.serrano@gmail.com.
Thank you so much for your support and availability. Yeah, I think we are good to end this session. Thank you again, everyone. And please keep an eye on our social media and our LinkedIn page. We will be announcing, hopefully, other sessions as well in the future. So thank you very much for joining, and enjoy the rest of the week.
Thank you very much. See you soon.
Thank you. Bye-bye.
Bye-bye.